Welcome back, everyone, to our continuing series on managing chronic pain during the opioid crisis. Recall that we're shaping these videos and we're being guided by the testimony at a recent congressional meeting of specialists in pain management. And this time we're going to focus on the testimony of Dr. Gazelka, who is a pain management specialist physician at the Mayo Clinic in Minnesota. She brought up a lot of great points about how physicians view chronic pain and how we approach each individual patient, and also the need to balance each individual patient's needs with population health, with the requirements of managing a lot of people for certain medical conditions. Her first point, and probably her most important point underlying seemingly all of her testimony, in my opinion, was that pain management is individualized medicine. We need to have the freedom to treat each patient on an individual level, given their individual needs, symptoms, presentations, experiences with pain. No patient is the same as another. So when we talk about developing a treatment plan for each individual person, we have to be aware that guidelines, and specifically in this testimony, opioid prescribing guidelines, aren't a replacement for clinical judgment. And this can be broadened to apply to any part of the treatment plan. As pain management physicians, we not only work with medications, but interventional treatments, ordering imaging studies, ordering physical therapy, ordering behavioral therapy. And oftentimes there are restrictions on this care through guidelines that don't make sense for that patient. A big catchphrase is evidence-based medicine and how we need to develop our treatment plans based on that. But oftentimes there isn't evidence to necessarily guide each and every step. For instance, opioid therapy has never been studied beyond 12 weeks in the management of pain. But yet for pain outside of 12 weeks, there are many different guidelines. And that means that we need to have the flexibility to work with guidelines when there isn't hard and fast evidence to say in an algorithmic way, you need to do X and then Y and then Z. Also, restrictions on ordering imaging or procedures have guidelines that support the decision by the payer that aren't necessarily borne out by studies. For instance, I'm not aware of a study that demands an MRI every 12 months if I'm providing procedures for a patient, or the demand that physical therapy be done for a certain number of weeks prior to getting authorization for a procedure isn't based on any evidence-based literature that I'm aware of, but it's a restrictive policy that's in place that prohibits treatments we can provide. And we need to collaborate with other physicians and insurance companies, all of the players here, to truly allow physicians to make an individualized treatment plan, since, as Dr. Gazelka said, no patient is the same as another. Another example is pain rehabilitation. And that's something that isn't necessarily always covered by insurance companies. And these are intensive programs where the whole person, their comorbidities, their experience in life is addressed in a very intensive way. And these programs are often they take weeks to perform and complete for the patient and can be very helpful in redirecting their life and managing with chronic pain. That's a more intensive step than the outpatient treatments we do. But that was another example that Dr. Gazelka gave of a very important way that we can help to improve pain, but it can be a struggle to get coverage for. When we think about opioids specifically, again, she said an individualized approach to care is paramount. So looking at dose limitations on opioids and each individual person that needs that opioid after a surgery or even for acute pain requirements, not everybody's the same. And so that was another example she used of needing to take the individual patient into account while also balancing the safety of the population at large and the exposure of opioids to people who sometimes it's not intended. So to summarize, individualized medicine is a part of pain management, and we need to give physicians and patients the freedom to operate within certain parameters that look out for safety and overall well-being, but also give them the flexibility to pursue treatments that can be helpful for each individual person, since everybody's experience with pain is so unique. Thanks for listening today.